Hello, my name is Jeff Messier. I'm a professor in electrical and software engineering at the Schulich School of Engineering at the University of Calgary. And this AI for Homelessness talk is a talk that I'm giving at the annual general meeting of the AI for Public Health organization that is being held in Calgary in July of 2024. So to start, I'd like to say I'm really thankful to live in Calgary, which is located in the and on the ancestral lands of the Treaty 7 people, which include the Blackfoot Confederacy, the Siksika, the Piikani, the Kainai First Nations, the Tsuut'ina First Nation, as well as the Stoney Nakoda people, which includes the Chiniki, the Bearspaw, and the Goodstoney First Nations as well. Um, these are the lands of the Métis Nation of Alberta Districts 5 and 6. I also really want to express my gratitude to all the agencies and organizations that have partnered and supported this work. Here are the just some of the agencies that I'm grateful to work with. So to start off this talk, I'm going to give a little bit of context. And so my title, AI for Homelessness, is kind of an intentional riff off of the title of the AI for Public Health organization. So their short form is AI4PH. And you know my so this is a talk very specifically for the AI for Public Health audience. If you're interested in kind of my more general talks about AI for homelessness, check out my website. The QR code is at the end of this presentation. And you'll see some more kind of general talks that maybe give a more general overview of what I'm about. This talk is very specifically for the public health researching audience, and I want to talk about how somebody doing AI for public health research can very effectively collaborate with the homelessness serving community. And I also want to sort of argue that if you're working in public health, it is very much in your interest and within the mandate of public health to also be considering housing and homelessness. So this is a very sort of in a way, sort of a sales pitch for people working in public health to get them more involved with homelessness and working with housing and homelessness agencies. So this first slide is to make the case that homelessness and experiencing homelessness is a public health problem, and hopefully this is kind of a logical argument. But just to kind of drive that point home, first of all, a lot of people experience homelessness. So this has an effect at the population level. In 2018, the point in time count, which is a one-day count of homelessness, found just under 3,000 people experiencing homelessness in Calgary, if we just want to focus on the community of Calgary. Also in Calgary, the Calgary Drop-In Center, one of the larger shelters in Calgary, sees about 200 new people per month. That's people that they've never seen before. And, the people who are experiencing homelessness also typically and disproportionately are experiencing health challenges. And these statistics come from the Calgary Recovery Services Task Force report. I've got a screenshot of that here. Most of the research was done by Dr. Katrina Mullaney, a homelessness researcher at the University of Calgary. And in this, the survey in this report found that 44% of the people experiencing homelessness in Calgary have a physical or mental disability. 51% are struggling with addiction. 47% have been victims of violence. And obviously this is has a direct effect on someone's health. To expand on the point a little bit further, if experiencing homelessness is a public health challenge, working in community and specifically working with housing itself is has a direct impact on the health of the people experiencing homelessness. So the current healthcare system and accessing it in sort of the traditional institutions like the hospital or the family doctor's office often doesn't work for people experiencing homelessness. So just citing the paper, the JAMA paper in the screenshot here, this paper found 1 in 4 people experiencing homelessness cannot access the medical care they require through the traditional channels. And also, housing and the lack of it has a direct impact on people's health, to the point where, there have been doctors in various places, around North America that have started to write prescriptions for housing as a way to have a direct impact or direct positive impact on someone's health. And so not only is homelessness, I think, a public health problem, a public health crisis, working within community outside of the traditional healthcare system and thinking about things like housing as a way to address health and sort of these non-conventional solutions and delivery methods are part of the way that we can address this problem. So, having zoomed in on the public health part of the AI4PH kind of acronym, now I'd like to focus on the AI part, because not only is housing and homelessness part of the public health part of this organization, specifically the artificial intelligence work being done by public health people has a real chance to have a direct impact in the homelessness space as well. So basically, the public health AI work that's being done can be ported over to the housing and homelessness space, actually with probably not a ton of modification. So the housing and homelessness system of care documents and delivers services by collecting a large amount of administrative data. And this is exactly the same as the healthcare system. So in the healthcare system, we accumulate a lot of medical records through electronic medical record systems, or EMRs, recording how and when people access different medical services. Very similar data is recorded within the housing and homelessness system to record how people access services within that system. And delivering services within a housing and homelessness system of care is very similar in many ways to clinical medical practice. Somebody will make an appointment, will come in with a series of complaints or problems that need to be addressed, a description of how they're doing, and it's up to that frontline caregiver to sort of listen to the person and recommend the appropriate treatment or appropriate intervention. So you might sit down across from somebody and have them describe their employment situation, their mental health, physical health situation, any information around addictions that they might be dealing with, and natural supports, family, all that kind of stuff. And then the frontline person would take all of that information and try to suggest or connect the person to the appropriate housing solution with the appropriate supports. Very similar to a family doctor listening to sort of a description of symptoms and then coming up with the proper treatment for it. And because of this, guidelines around how AI should be used in a medical setting actually would have a lot of value in the housing and homelessness system as well. I also think that taking AI methods or ideas from the developed for health and moving it into housing and homelessness has to be a partnership with communities. So first of all, data from community, from the housing and homelessness system of care, needs to be incorporated into the AI tools themselves. And I'm going to talk more about the types of data that we can find in the housing and homelessness system. But we're going to see that a lot of the data, a lot of the administrative data that's collected in housing and homelessness contains a lot of information that's very relevant for health, not only social determinants of health, but actually literal health information. And I also believe strongly that any AI tools that are going to have an impact on housing and homelessness need to be provided to community. They need to be integrated into the housing and homelessness system of care. It's not sufficient just for these tools to be running within the healthcare system only. The first reason, again, is because housing and social support work is very similar to clinical medical work. So tools developed for frontline clinical practice, I think, can be adapted to frontline work in housing and homelessness, and I'll talk about how that might work. And there are services provided within community, housing as one, but also things like detox services that directly affect a person's health. And honestly, people experiencing homelessness are often more comfortable interacting with agencies in communities than they are going into, let's say, a hospital setting. Okay, so now that I've hopefully made the case that, work in AI for public health is very adjacent and can potentially have a big impact in housing and homelessness, I want to talk a little bit about the housing and homelessness data ecosystem. Just, if you've got a health background, I'd like to give you a bit more of an idea of what type of data exists within housing and homelessness, and hopefully maybe get you excited about working with some of it. And so data within housing and homelessness is both familiar, but also in some ways challenging. So first of all, what's familiar about it? Well, it's tabular administrative data, just like you would find in an electronic medical record. So it's stored in databases that are very similar to what's used in healthcare. Each time a person accesses a housing or homelessness service, it's recorded in a separate record, just like an EMR system records a visit to a doctor's office. Each record has, typically the name of the person accessing the service, the date, the time, the staff people that are involved. There is some limited use of codes, mostly indicating the type of service. So this person was in for, a housing referral or an employment visit or needed to sleep at a shelter in the evening. So there's sometimes codes indicating that. However, there are some things that make data within housing and homelessness a little more challenging than medical data. First of all, data tends to be quite fragmented. So there are many agencies working within housing and homelessness, and the data collected by those agencies is often fragmented and not sort of merged or centralized. It's not like everybody's using a common IT system, although some communities, Calgary being one of them, does have a common IT system to a certain extent. Another challenge is that there's no unique identifier for people accessing housing and homelessness services. So there's no equivalent to the provincial healthcare number. People are identified only by their name, typically, and often the names aren't recorded the same for the same person. So my name is a great example. I'm Jeffrey with a G. My name is spelled Geoffrey. People spell my name with a J all the time. Sometimes I'm Jeffrey, sometimes I'm Jeff, and this is just an example of how my name might be recorded in a different way as I access different services. And the other thing is that most of the really interesting information in housing and homelessness system databases are recorded as text-based case notes. So housing and homelessness agencies tend to be very case notes focused, and they don't make the same use of diagnostic codes or treatment codes like the healthcare system does. So now I'd like to talk a little bit about some of the work that we're doing to address some of the challenging aspects of working with housing and homelessness data. And so, first of all, I'd like to talk a little bit about some work that we've done on data linkage. As I mentioned, data is often fragmented between services, but it is possible to link that data together in order to get a better idea of how groups of people move through the system of care. And so the example I'm going to present is some work that we did to link youth data from the Trellis Society, which is a youth serving agency in Calgary, to data from the Calgary Homeless Foundation, which records data for adult services. And so in the Trellis data, we had about 21,000 different client profiles spread across 75 different programs. In the Calgary Homeless Foundation data, we had 264,000 client profiles spread across 150 different programs. Now, this doesn't mean that we had 264,000 people experiencing homelessness in the data, because each time the same person accesses a different program from a different agency, a separate profile is created. And so our challenge is to merge those profiles together to see how many actual people we have in the data. And the value of linking in this particular example helps us understand how young people transition into the adult system of care if they're experiencing homelessness. We had to link with names and birth dates because there is no unique identifier, as I mentioned. So we used a technique called Bloom filtering to scramble the names and birth dates in order to protect the privacy of the people in the data. And Bloom filtering is a particular type of encryption that still allows us to calculate a similarity metric for names. And so names that are similar, for example, like Jeff with a J or Jeff with a G, we can use machine learning to recognize that those slight variations still represent the same person. And when we did this, so in total, we had about 284,000 profiles. We had to compare each profile with every other profile, and so there was about 40 billion comparisons. But with some kind of good programming techniques and some use of parallel processing, this comparison took about 5 hours to do. And here are some of the results. So of the 21,000 profiles in the Trellis data set, we actually linked that down to about 18,000 people. From the 264,000 profiles in the Calgary Homeless Foundation data, we found that represents actually only 98,000 people. And we recorded some statistics as well regarding how many people had only one record in the data versus 2, 3, 4, and so on. And so not to dive into the details of these numbers too much, but the lesson was it's really important to link, right? So don't assume that every single record you have is a different person, because in many cases, like especially in the adult data, we went from 264,000 records down to really just only 100,000 unique people. And so what can you learn when you do this kind of linkage? Well, you can do kind of cool studies of journey mapping. So for this particular example, we found happily that 88% of the youth that accessed Trellis services did not appear in the adult system of care at all, which is what you want, right? You don't want people to continually make use of the housing and homelessness system. Of the 12% that did show up in the adult system, we can create flow diagrams that help us understand how people flow through the system of care. I'm not going to dive into the details of this diagram at all. Beyond that, to say the positions on the left were different categories of programming at Trellis. The middle was how people predominantly accessed the adult system of care, and the column on the right was how people exited the adult system of care. And so if people do flow into the adult system of care, we would like to see them primarily accessing case management and housing programs. We don't want them to make heavy use of shelter. But this type of picture allows people who are designing and evaluating programs and interventions to understand how well they happen to be working and where we could be making improvements. Another challenge with housing and homelessness data is the fact that most of the information is contained in case notes rather than kind of diagnostic codes. That's challenging for artificial intelligence because we like to have sort of categorical features that we can work with. However, AI is great also at extracting information from text as well, and this is where the use of large language models comes in. So my group is in the process of looking at large language models for extracting meaning from case notes data in housing and homelessness. I don't have those results to present, but I've just got sort of some preliminary numbers showing kind of the scope and extent of case notes data within, in this case, the data of the Calgary Drop-In Center. So for people 25 years and older, we took a look at 2 date intervals. We have a pre-COVID date interval, July 1st to 2009, up to basically the start of lockdown. The COVID period runs from the start of lockdown to the end of March 2022. 16,000 people in the first cohort, 1,800 people in the second cohort. So if we're looking at how many people within the data actually had case notes written about them, we see pretty good coverage. So before COVID, about 61% of people in the data had case notes written about them. So there's information in the data that we could pull from those case notes. And, about a comment a week written for a person. So that's the frequency. This changes a little bit in COVID. We see an increase in the number of case notes recorded during COVID, up to 77%, slight increase in the frequency as well. And like I said, to really extract meaning from these notes, we need large language models, which we're working on now. But these pie charts are just a simple sort of keyword count from the data, just looking at keywords related to a bunch of different categories: addiction, mental health, conflict. There's a bunch of words that we associated with just positive things, words like happy or smiled or laughed. Negative words, yelled, cried, angry, things like that. And we can see some, variation between the pre-COVID and COVID data sets. Interestingly, the proportion of comments related to health went down. Anecdotally, this was because a lot of the pre-COVID health information was kind of like small medical services that people would access, things like foot care, wound care, stuff like that they would that people would access within shelter, with like nurses that were either on staff or were coming to the shelter to work. A lot of those sort of smaller services stopped during COVID. We see a higher proportion of conflict words. People were just on edge. And so you can extract some meaning from this, but we're excited to see what large language models will be able to do in terms of going a little bit further than just keyword counts. So that's just kind of a survey of what data is like in housing and homelessness. And now I'd like to talk a little bit about how I think AI can be utilized within community. And first of all, it's really important that AI, for it to be useful in housing and homelessness, it needs to be accessible. And most not-for-profits work with fairly basic IT infrastructure, spreadsheets, databases. They don't have, high-performance supercomputer clusters, GPU clusters, the kinds of things that we kind of take for granted when we're working in an AI research environment. And so any kind of AI or AI-inspired tools that are used in community must be compatible with the existing community infrastructure. And so a great example of a family of AI techniques that would work well in community are rule search, or is rule search machine learning. And so rule search machine learning is basically sort of logical, if and or type Boolean rules that you can actually enter by hand into basic sort of spreadsheet or database queries. But to find the best possible rule, that's where you use more sophisticated kind of search techniques that need to run on kind of advanced computing infrastructure. But the reason why this is sort of attractive potentially for housing and homelessness is because you can, working with an AI partner, use some advanced computing to, exhaustively search the rule space for a particular rule that's good for detecting a particular condition that you're interested in. But once you have those rules, applying the rules doesn't really need any advanced computing infrastructure at all. In some cases, you can literally just enter them by hand. And so how might AI tools be used in the delivery of services in housing and homelessness? So, I'm very outspoken in my opinion that automating decision making within housing and homelessness using AI is a bad idea. I don't think that it makes sense, or definitely doesn't make sense, and it could in fact be really risky to have an AI tool that decides who does or doesn't get connected to a certain supportive housing program. I believe very strongly that human decision makers need to be the ones deciding this. But I feel as though AI can be used to support the human decision makers and give them more information about a person's context to help them make better decisions on how to support a particular person. And this is where I think an analogy between the delivery of healthcare and the delivery of housing and homelessness services really can be useful. And so housing caseworkers and physicians, for example, have a lot in common with how they make in how they make decisions. So they'll talk to a person about their history. How have you been feeling? How long have you been feeling? How long have you experienced homelessness? Do you have any natural supports in the city? They will also take a person's current condition into account. How are you feeling today? Does it hurt if I press in this particular place? How are you doing right now in your job search? Have you been able to connect with your parents? How's that going for you? But physicians have something that caseworkers don't. Physicians also have access to a variety of medical tests that will give them more information about how a person is doing. Things like blood pressure tests, lab tests. And, a blood pressure cuff, for example, is not going to make a decision for a doctor. But it will tell the doctor if I am in elevated risk of a series of, cardiovascular related disease or problems. And we don't have an equivalent in housing and homelessness. So is it possible then maybe to use machine learning to kind of make the data equivalent of a blood pressure cuff for housing? Not something that will make a decision, but something that will give the decision maker a little bit more information. So rather than a housing intervention blood pressure cuff, can we use machine learning to estimate whether or not a client is at risk of a particular outcome? And machine learning generally is pretty good at that. And so we've done a little bit of work on at the Calgary Drop-In Center on developing techniques to indicate whether or not a person is at risk of becoming a long-term shelter user. And just as a bit of context, from 2007 to 2020, the Drop-In Center saw an average of 268 clients per month. And if we broke those down, we found that 85% of those people actually were out of shelter very quickly. A week or two, they were gone. So the vast majority of people who access shelter don't stay very long. 12% use shelter over a longer period, but their usage pattern is intermittent. And only 3% are that sort of everyday, month after month, year after year, sort of long-term shelter users. And most supportive housing programs prioritize chronic or long-term shelter users for housing supports. And so how do we know who is a long-term shelter user? Well, one way is to wait a long time, but this is a terrible idea because if this is someone's first day in an emergency shelter, if we say to them, well, if you're still here in a year, we'll help you. A year is a long time to live in shelter because it's a very difficult place to be. So that's not an acceptable approach, but maybe we could use something like machine learning to detect whether or not there's something in a person's early pattern of shelter use that suggests they are at risk of becoming a long-term shelter user. And that's what we did with rule search AI. So we use rule search techniques to look at someone's first 60 days in shelter to see if we could develop rules that indicate whether or not a person was at risk of becoming a long-term shelter user. And it turns out you can use pretty simple rules for this. So here's an example. If someone sleeps in shelter for 54 or more days in their first 60 days, so in other words, if they're always around, and if their meetings with counselors are less than a certain threshold, so they're around all the time, but they're not really accessing the supports that are available, chances are they're going to develop into a long-term shelter user. Very simple rule. You could enter this by hand into a spreadsheet or a database, and the performance is actually not bad. So 70% precision, 77% recall, and you would hope for better maybe, but remember these rules are not meant to be the only way that decisions are made. This is a blood pressure cuff, right? It's not the only thing that happens when you come into the doctor's office. This is just one more tool that the human decision makers have to make their decision, in addition to all of the other programs and all of the other ways they're connecting with people when they come into the doors of a shelter for the first time. Okay, so to wrap up. So if you are a researcher who's working on AI for public health, I hope that what this presentation has done is to get you excited about working in housing and homelessness as well. Again, I feel as though housing and homelessness is a big public health problem, so it's one of our big challenges. And the artificial intelligence that's being developed for use in the medical system really can jump over to housing and homelessness without a lot of modification. And so I hope you're excited about potentially working, incorporating housing and homelessness into your own work. And so maybe the last question I should answer is, maybe you're thinking, how can I work with community housing and homelessness data? So that's not the question you should ask. The first question is, how can I work with community, period? Right? So rather than just sort of going to an agency and saying, hey, give me your data, how can I work with your data? Go to that agency and basically say, how can I help? How can I develop something related to data that is going to make a difference for how you deliver services? And this is a bit of a change. If you've worked in the healthcare system predominantly. So one thing that's great about the healthcare system is that, research papers do change how people deliver healthcare. So medical practitioners do keep an eye on the peer-reviewed scientific literature, and as papers come out, clinical practitioners notice what are said in those papers, and they change how they deliver medicine. However, just publishing in peer-reviewed papers typically is not enough to cause change in housing and homelessness. What you need to do instead is to try to develop technology and tools that can transfer into community. So it's not the information, it's not the paper, it's the tool itself. And maybe this is a very engineering perspective, and of course I would take this, but I think the way to have the biggest impact is to develop a tool or technique or method, or to solve a problem or a question for somebody in community that can use your results right away. Yes, publish as well, but that's not going to be what causes the change. And so once you've connected with a community agency and you know sort of what kind of work would make a difference for them, then you can say, okay, now how do I start working with your data? And working with the data, if you've worked with secondary data from the healthcare system, it's a similar process. So of course, you have to start out by getting ethics approval from your university. Once you have that, typically you need to put in some legal data sharing agreements between your university and not only the agencies that you're going to be working with, but also sometimes the provincial government as well. So a lot of the data that I work with, for example, is under the umbrella of the Ministry of Seniors, Community and Social Services in Alberta. So I need to have an agreement with the ministry as well as an agreement with the actual agencies that are providing the data. Okay, to summarize then, AI for public health really is AI for homelessness, in my opinion. The purpose of this talk, of course, was to convince you of this, and hopefully, even if I haven't convinced you to completely abandon your career in public health, at least if you are working in public health, I hope that you're now more interested in incorporating aspects of housing and homelessness in your work. Homelessness is a huge public health challenge. Aside from some challenges working with housing and homelessness data, you will find that a lot of the administrative data in housing and homelessness, it does feel pretty familiar if you're used to working with medical data. The use case of AI for delivery of clinical services is pretty similar to the delivery of housing and homelessness services as well. And we need your help, basically. So the healthcare system has resources, capacity, funds that often aren't available in the not-for-profit housing and homelessness sector. And so tools and leadership developed within healthcare can have a real impact in housing and homelessness as well.